We are in for a real treat to hear Farah Hanley speak today. She's going to be talking a little bit about what the department is doing, how it's come through the pandemic, and what the plans are on the all the key issues that we've been talking about already today and will throughout the rest of the day. So without further ado, Farah? Yeah. Yeah.
Thank you, Vern. You can hear me, right? You guys are like all organized. You got the microphone working when it's not supposed to be working, and now it's working. So thank you. So great to be with all of you here today. Really looking forward to this opportunity. You know, I've worked with many of you for many years, and so really excited to kind of hear about what's happening in your areas and sharing with you what we're trying to do here at the department. You know, when I started my stint in state government many moons ago, Vern was the state Medicaid director. And I learned at that time the difference between Medicaid and Medicare. And I learned about what fee-for-service meant and what this, you know, blazing trail called primary case management was that we were embarking upon. So fast forward 29 years later, lots have changed. And so I'm really excited about this opportunity to be here with all of you and to just really talk to you about some of the exciting things we're doing. You'll hear me use the word excited a lot, and that is not an understatement. I am really thrilled to be able to work with teams and work with the team at the department to impact the lives of everyone we serve. So grateful for the opportunity. Thank you. Am I doing it? Yes, it's working. Okay, so throughout this presentation, you're going to see something a little different. Numbers are at my heart. They're part of my DNA. When I started work, I was working on the Medicaid budget. And have evolved over time to really appreciate the quantitative aspect of the work we do. So a lot of you are policy wonkers, and I am as well, but I also have a part of me that really is a numbers person. So we're going to take a little bit of a different path today. I'm going to go talk to you a little bit about our revenue, our budget, our values, and our priorities, and we'll spend most of the time on that. But again, want to shift back to how the pandemic really affected state revenue and our budget, and ultimately our value calculus. After that discussion, we'll share with you a little bit about our administrative priorities, our policy priorities, and really how that's reflected in everything we do. And then really building off of that, we'll talk to you about the challenges and opportunities. And then we can wrap up. So I want to make sure I get this straight. So this is kind of, okay, thank you. I know I'm kind of short too, and I can't wear heels anymore because I've got herniated discs in my back, so I'm always like this. So this is the obvious. The pandemic affected revenue and budget. You know, it hit and everything changed. In Michigan, I want to talk to you about what that looked like. Because it's really different. I'm going to significantly condense the story and some of the impact and hopefully sort of set the stage for a broader policy discussion. As most conversations go, let's start with COVID. Similar to other states, our cases had various peaks and valleys, and we're currently sitting at around 2.4 million individuals in our state who have either had or have COVID. That is relative to the 80.5 or so million in the nation, so about 3% of our national cases. As of April 20th, our case rates in Michigan are slightly increasing. So we are seeing a slight uptick due to the BA2 variant. And so at this time, we're not expecting any significant issues. We're keeping a close eye on it, but no changes in hospitalization or mortality rates. All right, so let's talk about what happened. This chart, to me, I really like this chart, and it's not mine, it's the Department of Treasury's. This chart, to me, explains, on the left, Why, every time my husband and I went to Lowe's and Home Depot, there was a long line. You know, people were spending their stimulus checks. We were all trying to figure out how to make living at home work. And it resulted in large retail sales. Our online sales also boomed. And you've heard of this before, you know, huge increases across the board. In addition, we all decided not to sit next to people in a train and in a bus, and instead to buy our own vehicle. And so, of course, now we're seeing price hikes with vehicles, and of course some shipping delays and that kind of thing. But we continue to be paying for those prices and be waiting months to get some of those. Okay, so again, not very policy wonkish, but I'm going to connect the dots for you. We have our state general fund budget, and we track it over time. And over time, it's been pretty steady. In 2009, 2010, you'll remember the days of ARA. Some of us will remember, you know, the depression there and some of the additional federal funds that we received. So that's a little valley there, but for the most part, pretty consistent. And then all of a sudden, you have this wild increase in our state general fund. And so that really is building off of the chart from before, where we really looked at all the Home Depot and Lowe's purchases and all the car dealership purchases, and all of that combined with the federal money we received was just a recipe for a general fund revenue windfall. It was a historic 19% in 2021, you'll see on that chart. And while the red bars show 2022 and 2023 and even 2024 in the red, that's only because they're the change from the previous year. So the percent change from the previous year is still continues to be at historic highs. And you know, I want to mention one other thing. Our revenue changes and fluctuations make it difficult for us to figure out how much of it is structural and how much of it is one time. So we have to really part and parcel what the sugar highs were and what we can really count on going forward. So you heard all about the funding that states received, I think, on the news. We were hit with a large sum of federal funding to support the state through the pandemic, similar to our other states. There were 6 large federal appropriations, much of which funding went either to providers directly or came to the state and we dispersed them. So when you take this information and you combine it with the revenue changes I highlighted earlier, again, recipe for a general fund windfall. But part of the question is always, what'd you do with all this money? So first, what did Michigan receive? At DHHS, we directly received over $3.9 billion in COVID relief funds. And that's not the entire state. That's not other departments, that's just DHHS. The CRF is part of the CARES Act, the Coronavirus Relief Funds. The FRF was part of the American Rescue Plan. And you know, sometimes we forget, in the states, we actually leveraged a lot of FEMA money. FEMA really helped support and replace our state general fund match requirements. So we were able to tap into some of that as well. And there was a lot of other federal budget grants that we received. Many of them went to the public health side. So they either went to support labs, local public health departments, vaccines for children grants. We also received a lot of money to support our SNAP program, our food assistance program. So it's not just the CRF and FRF you might hear about. There were a litany of other federal grants we received. So again, what did we do with the money? We assessed across the spectrum where the funding needed to go and where the critical gaps existed. We knew we had to hit specific areas such as individual needs related to food, water, energy assistance, and other client benefits. We sent hundreds of millions of dollars to our provider partners, like hospitals, nursing homes, large health systems, for PPE, staffing, and capacity grants. We knew that the local public health departments were stretched, and we worked closely with them to provide them with the resources for testing and contract tracing. We also sent hundreds of millions of dollars to providers to support testing efforts. We closely monitored and worked with our mental health community to make sure we staffed them up and appropriately resourced them related to things like crisis and counseling services. And we were slammed with an unimaginable reality. We all started to run, assuming it was a sprint, and as many of you experienced, we realized that the sprint was really a marathon at a sprint pace. Okay, so now I'd like to shift a little bit to the segment of the presentation where I talk to you about what we did with all of this funding and how that affected our overall assessment of needs in our state. So what did the pandemic reveal, and how did that show up in our funds? So this is not a political presentation. Having worked for 2 Republican governors and 2 Democratic governors, I can tell you that I have heard something to this effect, either from them directly or from their staff. It's just not a political statement, it's reality. Don't tell me what you value, show me your budget, and I'll tell you what you value. Before I get into what the pandemic and funding did to our priorities, I want to take this information and really give you what more the pandemic revealed and give you some context for who we really are and what we do. And again, some of you have worked with the department, some of you not so much, and want to make sure that you all have that context of who Department of Health and Human Services is. This pie chart is, these are all just kind of fascinating to me. 3/4 of our $32 billion budget is Medicaid and behavioral health. And you look at healthcare, we have human services in our department, and I would say that there are, equally impactful programs on the human services side. But you'll see that we have a lot of funding that goes towards our healthcare programs. And even though the medical services or Medicaid portion is $19 billion, and even though our behavioral health is $5 billion, we still have Title XIX supporting our human services programs. So we're at around $25 billion in our Medicaid program in the state of Michigan. And I will note that $25 billion is larger than the worldwide revenue of McDonald's Corporation. So it is no small feat. And also over 90% of our state dollars are actually, of the dollars in the program are actually federal funding, and less than 10% is actually general fund. And when you look at the general fund, the bulk of it is used to match our federal funds. So we are far and away federally funded and very extremely limited in terms of our non-discretionary funding. So more about who we are. Again, while the human services side of our work may not immediately seem like it's health related, what we do with those programs often works to address the social determinants of health, factors like housing, environment, transportation, and the like. And if you'll see here, we provided 3.2 million, I'll just touch on a couple of them, 3.2 million residents with assistance to get that food on the table, afford childcare, and keep some heat in the home. We distributed test kits and encouraged and provided preventive health services for children and adults. And in addition to these numbers, our department included additional food assistance, making it easier for our families to access fresh, healthy foods, and an announcement of a My Benefits Center. And the My Benefits Center is designed to complement the work of our employees and our community navigators to assist our clients to apply for assistance and for benefits. So the pandemic revealed many things. I talked to you a little bit about what it revealed in terms of our human behavior, how that affected our funding. And now I want to talk to you about that it also revealed, as many of you have also painfully learned, that we have significant health inequities in our state. It revealed to us that the department needs to do all we can to be the most optimally prepared for the next emergency and the next pandemic. And I tell you now, we will have another one at some point. So let's be ready. And that's what we said to ourselves in the department. When we looked at the department, when we looked at our structure, we knew we wanted to shift from being proactive, from being reactive to the proactive. We were constantly in the reactive. And we looked across our organizational structure and said we can do better. So we assessed and we actually identified some opportunities. And I want to talk to you about the list of our administrative priorities as it relates to our department internal alignment and structure. So we reorganized. We said there wasn't enough attention being paid to the behavioral health side of the world, and that we wanted to align with what the pandemic revealed, and that was the need for structural and meaningful behavioral health supports. So the department, we agreed, needed to be more nimble with its resources, and we did so by creating this reorganization. We said bring more attention, bring more focus and expertise to the challenges coming to our folks today in the behavioral health space. We needed to improve our coordination internally and make sure we were ready for the next chapter. So this department restructure has really developed into a way where now we have more contract oversight, more financial oversight, and really taking a closer look at our complex grants and programs. To me, the Behavioral and Physical Health and Aging Services Administration is another area where we reorganized. This is really policy wonk talk for our traditional Medicaid agency, plus our long-term care and aging services, plus our behavioral health services for adults. And the new healthcare administration, this one, will really oversee some of those community-based services for adults with IDD, SMI, and SUD. It is a long acronym, Behavioral and Physical Health and Aging Services Administration. And again, while the administration is small, it's mighty, and it leads up, again, that corporation that's larger than McDonald's. We also said children's services in behavioral health is critical. How do we get more attention to children's behavioral health care? We took a step back and we said, children's programs and services are different than those for adults. Mobile crisis looks different, for example. We wanted to bring attention, so we developed and created a new bureau. I like to call it the Kiddos Bureau. This is the Bureau of Children's Coordinated Health Policy and Supports. I won't get into all the verbiage on the slide, but just so you have a takeaway, we've established a lot of new neat things. We've established a clinical review team and 3 separate divisions in this bureau to bring focus and attention to those needs. Our department's behavioral health structure, I think, is really now set up for success. With the children's focus in this bureau, with the adult behavioral focus on the Medicaid side, and in my new role, overseeing many of that, where the BP HASA is what we call it, led by Kate Massey, our Medicaid director. Just really exciting to look at and understand and assess, and going forward, leverage some of the expertise. So what are our policy priorities? The pandemic revealed a necessary exercise to assess what our policy priorities were. In addition to helping Michigan move forward with the pandemic, we have been doing a lot of things, and we really have centered our focus and our proposals into 3 categories. Protecting our most vulnerable residents in terms of health and economic stability, prevention programs that meet people's needs, and one of our biggest priorities, expanding access to behavioral health. Our public behavioral health system serves about 300,000 people in Michigan, including youth and adults. Through our 46 CMHs, through partnership through our CMHs and our 10 PIHPs. However, this is still only 1/10 of the 1.3 million Michiganders who are still living with behavioral health disorders and are served by the system in Michigan. So I'm going to spend some time talking about behavioral health. Our certified community behavioral health clinics is one way where our department is committed to identifying best practices to treat the whole person, from the neck down and the neck up. So last fall, we announced the expansion of our CCBHC demonstration, hoping that this model would eventually work across the state. CCBHCs are one of our state's integration efforts. The I word, right? Integration. CCBHCs are one of our integration efforts. We were hoping that this model will really be able to be replicated. We're getting really great data from it. It provides a service array to facilitate access, stabilize crises, address complex mental and physical health needs, and really emphasizes that integrative approach. We now have 13 CCBHCs across the state, and we'll receive the same Medicaid funding as any other health center. And we're really very excited about it. We could not have done things like this, I just want to reinforce, without the commitment of some entities. One is, of course, our providers who are actually helping to put boots on the ground to do this. And second is, we've had a lot of support and commitment from our legislature. They have seen, they agree that this is really the way that they want to go, and they understand, and we've worked really well with them to support some of these existing efforts. So one of the top priorities of the governor is behavioral health services. And last year, we supported and implemented investments from the governor and the legislature to help resources, for example, to help retired and existing mental health professionals in schools. We looked at where there were mental health needs, and I want to tell you, there is not a day that goes by that I don't have a conversation with a provider that talks to us about problems with individuals in places where maybe they shouldn't be. One of the key issues facing the state is demand for inpatient psychiatric services for either one of our state-operated hospitals or for specialized adult foster care and specialized residential settings. There are long wait lists for necessary services at Children's Hawthorne Center. That's our state psychiatric hospital for children. We've had conversations with the CMHs, with the hospitals, with the health plans. Everyone's really working hard to try to identify where to go from here. So what we said was, let's develop a proposal. And the proposal was, we're going to request 60 beds. And the 60 beds were going to be 48 for adults, 12 for children. And these residential beds were going to be set up so that we can move people out of hospitals into the community if that's where they belonged. We could move people out of state psychiatric hospitals into the community if that's where they belonged. And so we're really working closely with the legislature on that because we really believe we have an opportunity to change this. When we talk about healthcare, I think we would be remiss if we didn't talk about more than just the traditional health needs. This proposal really addresses some of the neck up issues we're working through with our foster care kids. And we're hopeful we can get some movement on this initiative. I was talking to someone not too long ago about foster care and foster care children and how to better support them. And they said, yeah, you know, it's tough because a lot of them are really traumatized. And I said, no, all of them are traumatized. All of them need support and services. So the program that we talk about here with our daycare treatment is designed to really treat problems stemming from those traumatic experiences, like self-harm or impulsive behavior, those types of things. The day treatment program Our Children's Services Director is really excited about this, so we're really hopeful that we can obtain funding for this proposal. This day treatment program is designed for children who require more intensive support than what's available through the conventional outpatient treatment programs. It has the potential to really get us some good outcomes too, and those children will be in school. It's really, they're at risk for being expelled from school or have been expelled from school, to get them in these programs so that we can help stabilize their placement. So we talk about the workforce. Can't live and breathe in the healthcare system and the healthcare industry without talking about the problems in the workforce. And we said, we know that Michigan ranks, so here's some statistics. Michigan ranks 3rd in the nation of shortages of mental health professionals. That's pretty abysmal. Michigan State Hospital System struggles to hire and retain enough qualified staff to provide psychiatric services. And a primary cause of the problem is compensation. So we've proposed a 3-pronged approach. To support and encourage our behavioral health providers and practitioners to practice in federally designated health professional shortage areas. We want to invest in our workforce development, and we want to support our first responders. And the workforce problems continue, and at least we're aware of them, and we're working really hard to try to address them. This is another thing that the pandemic revealed. Our direct care workers have been on the front line of COVID-19 and the public health crisis. These individuals take care of our most vulnerable population, and they are frankly a valued part of the community. There are approximately 165,000 direct care workers in Michigan only, and that's equivalent to about 4% of the total employment in the state. The DCW is overwhelmingly female, primarily has a high school degree, and is largely African American. The workforce has a diverse age range, and it's around 25 to 64. So when we looked at all that general fund, remember those budget slides I talked about and that big old graph that showed it exploding in 2021? And some of that was one-time money, and we said, let's get creative. Let's figure out a way to tap into those funds. How do we do that? So we suggested and proposed a recruitment and retention program for our behavioral health direct care staff, like a 1-year bonus payment, if you will. And it would be provided on like a per pay period basis. It would cover around 1,000 state psychiatric hospital direct care workers and around 45 or 50,000 of our adult home help workers. But it's not 165. So we need to do as much as we can to shore up and support this workforce. And we'd very much like to see this as an all-encompassing approach. Social determinants of health. Of course, the pandemic revealed, in terms of SDOH, a lot. The SDOH strategy in MDHHS is broad-reaching. We're trying to facilitate connections to health and improve quality of care. These are just 3 examples of a list of things that we're trying to address in Michigan. We have a Healthy Moms, Healthy Babies program that we're really excited about that we launched about 3 years ago. And we looked at it, and one of the things we wanted to do was extend the amount of time that a woman could receive postpartum coverage. So we proposed to CMS a 12-month extension to give them a 12-month continuous coverage. And last week, they approved it. So we're very excited about moving forward on our SDOH initiative as it relates to our health equity for our healthy moms. On the housing side, and I think this is kind of neat, and Phil will probably remember, we did some work on what we call the integrated services delivery and really treating the person as a whole person and trying to get them to the services they need. We are connecting now with MSHDA on resources within MDHHS to really develop these interoperability between systems so that our systems actually talk to each other, promote better services, and this is kind of trailblazing. We haven't really done this kind of thing before. What's exciting though about the ISD piece that I just mentioned is on food security, we have our MyBridges portal. An individual seeking public assistance will go into MyBridges, and they'll say, they'll apply for Medicaid or they'll apply for childcare. What's interesting about the new thing we're doing with food security is we have actually connected our community partners to be included in MyBridges. So for example, if someone doesn't apply, but they show up at a homeless shelter, the shelter gets into MyBridges, and guess what? That pings the department, and then we can go back and catch that person and work with them. So it's almost like a little bit of a reverse way to do it. Again, creative and trying to really, what we're calling it as a closed loop referral in MyBridges. So continuing on with social determinants of health, as I mentioned, the pandemic revealed significant health inequities. So as a result, we put together a proposal called Health Equity Across the Lifespan. So from birth till the end of life. And we looked at things like birth outcomes. Let's just start there for a second. We know that racial inequities in birth outcomes in Michigan are persistent. Black infants are 2.6 times more likely to die in their first year of life than white infants. And Black women are 4.5 times more likely to die than white women, than white pregnant women. So to address this, we've said, let's think about, and we are now proposing, doulas as a Medicaid benefit. I just met with one of the health plans last week, and they said they too were trying to do that. And I said, well, guess what? The state Medicaid program is trying to do that. So we're really excited about this. We know that doulas are trained birth workers providing the non-clinical, emotional, physical support that our women need. Data shows that doulas are safe, cost-effective, and they really provide that intervention for reducing the risk of complications. They're frequently reimbursed by insurance, and in addition to reducing costs, we really think they address reducing the long-standing inequities we have in the state. We're also proposing integrating 5 migrant family independence specialists at 4 of our federally qualified health centers. Agriculture workers face many language, health, and socioeconomic barriers, and so we're hopeful that we can really pull these workers in. And we're proposing to end Michigan's birth expense recovery program. The birth expense recovery program is a program where the state of Michigan recovers birth expenses from fathers of children born out of wedlock. We are one of 3 states that still do this. And we need to leave some of that money in for the family so that they can reinvest it with their family. And I know that the statistics right now, it's 34% of births are from white moms, and then the rate jumps to 58% and 72% for Hispanic and Black mothers. So again, really working through on the birth expense piece is going to be something that we're hopeful gets some traction. And then finally on the social determinants of health, again, the pandemic revealed large gaps in measures around child health, childhood immunizations, childhood lead exposure, lead screening rates. We knew we had an opportunity to do better. So our proposal we have various proposals, and one of them is to really build on the successes of our centering pregnancy programs, where there's a focus on prenatal care, support, and education, and also to build an incentive pool for our health plan partners to tap into. The payments could be made contingent on how well the health plans are faring in terms of their outcomes. We'll establish those for postpartum care, immunizations, and well child visits. So the SDOH strategy is broad-reaching, and it's really covering very much of the gamut. We're excited and hopeful that we can get some traction with these proposals. Shifting a little bit to Medicaid dental program, the pandemic also revealed that our access to preventive health services needed improving. Folks stayed away from healthcare offices, understandably, unless absolutely necessary, but it became clear that our system was fragmented and uncoordinated in some areas. So, including with the delivery of dental services. So this is an interesting graph because it really shows we run 3 different dental programs, all of them with different payment structures and different populations. And our utilization rates vary significantly, as you can see there. We said, let's try to do something different. Let's come up with a dental program redesign that improves access to dental care by 1, restructuring how the Medicaid dental benefit is administered, and 2, increasing rates so that they could be supportable for outpatient hospitals and ambulatory surgical centers. So we want to consolidate the fee-for-service, Healthy Michigan, and traditional Medicaid program for dental under 1 contract with the dental plan, and really raising reimbursement rates for our dental programs for adults and kids to give them better access to health care. And then we won't have all the utilization variances we were showing. So again, part of our focus to preventive health care. So I want to pause there and then just sort of now slowly shift to, with all of that and with everything we're trying to accomplish, what other things are sort of staring at us in the face that I haven't caught that are really part of our thinking forward? I think the slides are out of order, but that's okay. I can do this. Opioid settlement. So the opioid efforts are really interesting because we just settled with 2 large companies, Johnson & Johnson and McKinsey, as well as 3 distributors. And it really, again, pandemic revealed that opioid use was a problem. And we saw the data. We were getting some encouraging results saying that in 2018 and 2019, rates were relatively flat and maybe even going down a little. But the CMS data actually revealed that more people died of an overdose in 2020 of opioid use than any other year on record in the United States. So we're working to address this in Michigan. We've developed a state of Michigan opioid strategy, and that strategy is really centering around 8 pillars for prevention, treatment, services, and other things. We were the recipient of this large national settlement, so we're collaborating now with partners to figure out, that's a lot of money, $776 million, split across various areas, but what are great things that we could do with it? And then, of course, we're tracking the caseload increases since the start of the pandemic and what that means to the redetermination and the PHE, the ending of the PHE. Our caseloads have hit a record 3 million, 21% increase just from March 2020. So as you'd expect, we're keeping a close eye on the extension and what's going to happen with it and whether it's going to occur again. We're also assessing our local office staff support. We have a lot of local offices in our state, and a lot of people are going to be coming in trying to figure out if they're going to lose their Medicaid eligibility. We're also working closely with our health plan partners because they too want to ensure that if someone's not on their rolls, maybe they qualify for the marketplace. Maybe there's a different way we could get them coverage. And so all of our providers are really encouraged to see an all hands on deck approach. And every time I've met with at least one of them, there always seems to be some reference to what we're going to do here as it relates to the ending of the public health emergency. So keeping a close eye on that as well. And then I just want to wrap it up. I know I've been your, really very entertaining person for your lunch, but I do want to talk about ongoing efforts. The slide makes me a little nervous because We have so many things we're working on that's not here. Yes, we're focused on the direct care workforce. Yes, we're focused on behavioral health care. Yes, we're focused on improving and strengthening our SDOH efforts. But we're also looking at the full continuum of care. And we're actively working with our aging community to better understand their needs. I was just at the Commission on Services to the Aging conference last week and met with them and heard from them the successes they've seen with our home and community-based services waiver, our program, our My Choice program, serving nursing home eligibles in their homes. They talked about the PACE program, our program of all-inclusive care for the elderly, and how successful those have been. So we're really making sure that it's this full continuum, and that even on the long-term care side, we're trying to make sure we focus and address those issues. I mentioned being focused on the appropriate placement of people needing services. I can't tell you how many times we've heard people can't be sitting in emergency rooms and where they shouldn't be. They've got to be appropriately placed. So our wait lists are growing across the board. That's why we need to address the behavioral health access issue. And I also haven't touched on all the public health efforts we've undertaken to address issues that the pandemic revealed. But to get ahead of the next emergency, we're working to do things like update our public health lab and get our local public health departments ready for the next challenge. And again, I mentioned the I word, the elephant in the room is integration. We hear that word a lot. I talked a little bit about the department's efforts there, and we also have very successful opioid and behavioral health homes. So between that and our certified behavioral health clinics, we're really hopeful that those will really demonstrate true success, and the data is showing it will. So I want to thank you for giving me this time to just sort of talk to you about what we're doing here at the department. You know, you feel free to ask questions, although I will tell you, you are what's between me and watching maybe Miggy hit his 3,000th hit, so I'm hoping this doesn't go past 1 o'clock. Really appreciate your time. Thank you so very much.